Hello and welcome to Fit for Duty. I'm Dr. Larry Earl, your host and the president of the National Association of Occupational Health Professionals. Today we'll unravel the intricacies of occupational health, examining OSHA-regulated exams, workers' compensation cases, drug testing, and strategies for injury care. We'll also look at prevention strategies and the role of total person health analytics in uncovering root causes of workplace health issues, highlighting successful interventions that have made a real impact on employee health and well-being. Fit for Duty offers a comprehensive approach to occupational health, empowering organizations to build healthier and more productive workplaces. Join us as we break new ground, dismantle barriers, and seamlessly connect theory with practice. In this episode of Fit for Duty, we welcome back Dr. Diana Kraemer to explore independent medical exams and their significance in occupational health. Join us as we unravel the complexities surrounding IMEs, the pivotal roles they play in resolving cases, and how they can bridge gaps between employers and employees. Dr. Kraemer brings her insights as a seasoned neurosurgeon, shedding light on the nuances of conducting IMEs with objectivity and integrity. Whether you're a healthcare professional, employer, or simply curious about the intricacies of occupational health, this episode promises valuable perspectives and informed discussions. Okay, and we are on with Dr. Diana Kraemer. Welcome back. Thanks so much for joining us again here on Fit for Duty.
Larry, it is good to see you again. I enjoy doing these with you.
Yeah, absolutely. I do as well. Let's jump right into IMEs today. Can you just explain, first of all, what an independent medical exam, an IME, is? Why is it important to occupational health?
The IME is an examination that's performed when there is a question to be resolved in an injured worker's case. The IME can be either positive or negative, and my goal when I'm doing an IME is to figure out what the issue is that's is still being contended, has not resolved, and is keeping that worker from getting a best outcome.
And what kind of scenarios are we usually talking about? Is it always at the end of a case when the treating physician is sort of frustrated, patient's not better, or are there other times when we would also request an IME? And who does it? Who's requesting it?
Yes, that's a good question. Most of the patients we see have an injury, get better, go back to work, whether it's with accommodations or not. There is a small percentage, 10-15% of cases that don't resolve. And this is that 80-20 rule where 20% of the cases take 80% of the resources. And that includes, that's not just money, it's money, time, patience, our ability to, our empathy. Because when we have these refractory cases that aren't getting better, it makes us feel bad. Everybody's frustrated.
Yeah, we feel inadequate.
Yes. Our patients think we're inadequate.
Yeah.
Sometimes. The IME can essentially, the doctor can request one, the insurance company can request one. Rarely plaintiff, if there's an attorney injury, personal injury attorney involved, they can request one.
Yeah.
And basically the request is to solve a log jam. And that log jam can be diagnostic, it can be treatment, it can be administrative, it can be legal, and the IME can be another set of eyes. Now, the challenge for many of us is our natural reaction to feeling like somebody else is going to interfere or opine on our case when we are more intimately aware of what's going on with the person. We're sitting in a room with a patient. Why should Dr. Kraemer be butting in on my care?
Yeah, although I I know in myself, when I've asked for IMEs and when other docs that I speak with about this, sometimes there's also a relief. Oh, I can really get another opinion and hopefully some direction on what I can now do with this case because I'm frustrated. I don't know what else to do.
And I agree with you. There are times when I just see things differently. I'm a neurosurgeon. I get a lot of IMEs for OCMED situations, arms, legs not working, neck pain, refractory, post concussion. And one of the things I can do as a neurosurgeon and be a support to the OCMED doc,
Exactly.
where I may just, the four things that sort of are in the back of your mind, I can put together into a diagnosis. So sometimes as an IME, first of all, I'm probably going to have a lot more records than you ever had. I'm going to have stuff beforehand. I'm going to have stuff from other doctors that didn't make it in your clinic note. And I'm going to have this big perspective, and I'm going to be able to see everything you did, everything that happened over here that you didn't really know about. And I'm also going to have another specialty to look at it. So, for example, I may be able to say that whiplash injury, and then they had tingling in their fingers afterwards, and the surgeon wants to do a 2-level fusion, but on physical examination, the person has carpal tunnel and they've not had an EMG, and sometimes we just don't see the forest for the trees.
Yeah.
And that's normal. Okay, I do that. Sometimes I can just redirect the landscape.
Yeah, helpful. What's the typical process of an IME? Can you walk us through how that usually happens?
It's changing over time in our post-COVID days, but for a clinical examination, let's say I've been asked to see somebody, the first important thing, so I will get a case, I will get it assigned to me, I will make an appointment with that person, I will review the records. Then I sit down and the way I like to do is I just try to put the person at ease, because by definition, for the most part, somebody's telling them to be there and they don't necessarily want to be seeing me. So the first thing I think in doing a good IME is getting the person leaning forward and saying, well, this happened, and giving the sense that I am listening and I'm here to try to move the case forward. So I have an appointment with a person. I sit down and listen to them. I do a directed history and physical to the problem, but I also do kind of a broader psychosocial screen in the background. And then I do a directed examination. And for my neurological evaluation may be a little bit better than a typical clinician's. My cardiac examination is probably a whole lot worse. But my neuro exam I may pick up things that somebody else doesn't see. And then I'm going to be able to synthesize all this. So I say, do the examination, thank the person for coming in, let them know they'll be receiving a report, and then try to write my report in a neutral way that expands opportunities, shuts appropriate doors to be shut, and helps move the case along.
Yeah. Yeah, great points. You touched on this a little bit in terms of your background and qualifications. What type of examiner should be seeing the case? You're a neurosurgeon. Is it always super specialty person that needs to see all OCMED work comp cases?
No, and I think a lot of times OCMED is great for seeing OCMED cases. There can be, for example, in occupational medicine, a lot of times the question is fit for duty or return to a safety-sensitive work, where the IME can support the doctor, the treating doctor, in coming to a safe decision. There are times when it's a real conundrum about whether or not you should allow someone to go back to a particular type of work.
Yeah.
So in terms of the whole construct of risk, capacity, and tolerance, it may be helpful to have an IME help you support or refine your clinical impression. That's very broad. So clearly, as a neurosurgeon, I see, the kind of one far spectrum of neurosurgical disease and injury. But I see a lot of backs and necks, concussion, headache. So I have this strange, very specialized and very generalized situation. But many IMEs are ortho, OCMED, sometimes internist, PM&R. And so you don't have to have a subspecialty interest. And I think OCMED docs are valuable for being IMEs, for their generalized overview and their ability to examine all body parts, which I'm technically not qualified to do.
Yeah. Let's talk about some of the legal and ethical issues surrounding IMEs. What should occupational health professionals be aware of?
I think it's important as from an ethical issue to understand that the IME evaluation is fundamentally different than a clinical treating relationship. I never take my MD hat off. However, my role as an IME is different. My role is to be independent, whatever that means. It's to try to be objective. It's to try to take a different slant on things. The history taking is different for my patient in my office versus a claimant or somebody being examined, because there's no positive word other than Mr. or Mrs. Jones for anybody I'm sitting across from. We'll get to that in a minute. The physical exam is different in that if I'm, for example, doing an impairment rating exam, I am required by AMA guides to do different examination techniques or parts of an exam that I would not do for a clinical exam. Circumferences, range of motion.
All the measurements,
Measurements. All of those things are different ethical issues, whether or not I can tell the person what's wrong with them. There's an important ethical guideline that I include in my conversation, my introduction to a person. The AMA guides ethics for independent medical evaluations states that if you find something of concern, not only should you inform the person, but if requested, you should help them obtain care. That is within the guidelines of your non-treating role as a physician. And there's been more than one or two or even three times when I've sent someone to the ER. And where we tend to see that the most would be for most doctors would be hypertension. If somebody walks in with a blood pressure of 210 over 100 in your office, and okay, yeah, you got to take care of that. But a lot of times I see some pretty crazy stuff. And I say, we really need to get you to the ER now.
Yeah, you're not entering into a physician-patient relationship with any of these exams, even in those cases.
Yes, I am not treating the person. Okay, I am a referee. But if the building's on fire, it's my job to intercede in my role as the physician.
And what if you feel there's a misdiagnosis? Are you then making a diagnosis, and is that considered a physician-patient relationship?
It is not. So that's one of the strengths of being an IME is that if I'm doing my job right, I may come up with diagnoses that have not been previously made. Yeah. And it's important. If we are not treating a person for the right thing, the chances they're going to get better go way down. That's one of the things I like doing most as an IME is looking at what's in front of me, looking at the records, adding neurosurgical examination, history, different viewpoint, and going, well, maybe it's not, neck strain whiplash with cervical radiculopathy. Maybe we should put wrist splints on that person.
Yeah, you mentioned the carpal tunnel example. Absolutely.
Yeah,
very good. We talked a little bit before the session about impartiality and objectivity, and we just mentioned it, but you said sometimes there are biases. Can you explain what you mean by that?
Yeah. In a nutshell, anybody who says they're not biased is biased. We all have biases. We have
Yeah.
biases, intrinsic, external, and it's just who we are. We all have them. And I think the best way to start to address bias is to understand that you have it. And there's actually literature to that effect that says the best thing to do to combat bias is to try to acknowledge that it exists. Because until you start to internalize this concept that we all have intrinsic biases, it's really difficult to change that. So, one of the things one of the most important, fascinating areas of bias that I've seen recently is something I think we all do, and that is the difficult patient. Okay. So, if a person is perceived to be a difficult patient, the diagnostic accuracy of their condition goes down. You're more likely to make a misdiagnosis or miss a diagnosis in someone who's perceived as difficult. And I think that plays really well into this entire concept of the need for the IME, because
Okay.
these are the contested cases.
Right.
And maybe we're not getting it right through no fault of the doctor treating the person, but it can be a communication bias, it can be a gender bias, it can be a race bias. I saw a gentleman who was non-fluent in English, and I think it affected his care. And I like to think that I helped by focusing more on the neurosurgical objective findings and changing the dynamic.
Yeah, interesting. Is there bias also? I know this comes up in medical legal because you're working for one or the other usually. Is there plaintiff defense bias in a typical IME for a work comp case?
So the standard answer is I'm being paid for my opinion, or am I being paid for my time? The opposing counsel is inferring that I'm being paid for my opinion, and what I'm trying to do is be paid for my time. And the bottom line is that someone is paying me.
Yeah.
And I think going to that sense of intrinsic bias of saying, oh, it doesn't matter who's paying me. I mean, that doesn't pass a sniff test. There's a string there. There's a connection. Where I try to go with this and what I try to communicate is two things. One, my reputation is more important to me as being an accurate, not fair, because that's in the eye of the beholder, an accurate evaluator, and to give the impression that my reputation is more important, and being able to come back another day and evaluate another case based on my credibility is important.
What are some of the common challenges you face when performing IMEs? How do you address those? We just talked about a couple of them. How do you handle discrepancies between findings of an IME and other medical reports? We talked about misdiagnosis. Sometimes there's been another IME that's already been done. Maybe you disagree with that. How do you handle all that?
I handle it respectfully, okay, and with neutral language. My job is to give an opinion, try to be ethical and accurate. My job is to put the person at ease. My goal is to get somebody who from this to this during an examination.
Right.
I want them leaning forward. I want them telling me what's going on. I will frequently dictate the history in front of them. Did I get this right? And they're going, yeah, or no, it was after, not before, and they're leaning forward and they're helping me get this history. And it can solve problems. The challenge, so first of all, the challenge is that somebody made them come in. Okay.
Yeah.
The second challenge is I am seeing things through a different lens, and there can be multiple opinions, not from one doctor, from multiple doctors. And I have to integrate all of those. The exam may be inconsistent. And I think it is very important not to try to throw shade on the exam or the examinee during the examination, but just to say, Mr. Jones had difficulty standing up and had to use his hands on the chair 2 times, but then whatever. You just describe it. You describe the actions in the room in neutral language. When you make a diagnosis, you say, I see this, you in neutral terms. When I make treatment recommendations, I make them in neutral terms. If I go into the examination with the concept that I'm trying to move a case forward and resolve dispute, it solves a lot of those tension points.
So you don't really have to address, oh, I disagree with this. You're just stating matter-of-factly what your findings are, and you don't really dwell on that.
I respectfully disagree with Dr. Jones' opinion based on I see this, and this.
Okay.
I don't have to call him a cone-nosed bug.
Right. Right, but you will call it out. All right.
So I see this differently. I respectfully disagree. And then I'll give 4 reasons. If I'm doing my job right, or I'll just say, I see that this person has this based on these 4 things, and these are sufficient to explain his symptoms. He does not need this diagnosis of, okay, let's go back to our person with carpal tunnel. I don't have to say, I don't think he needs surgery. Okay. I don't need to say, why would you operate on or do neck surgery on a person with carpal tunnel? All I need to say is, on my physical examination, I see signs of carpal tunnel. I recommend nerve conduction tests and wrist splints.
That really leads into the next question, right? How can the findings of the IME affect the patient's treatment plan or return to work timeline? So that's what you're talking about.
One of the founding principles of the guides is correct diagnosis. And it's amazing how often we are incorrect, and it is amazing how more often we're incorrect in dealing with a difficult population. So I think fundamentally when doing an IME, I'm trying to get back to the correct diagnosis. And that does not mean that I'm trying to outguess or rearrange the attending physician's diagnoses. I'm looking for alternative diagnoses, additional diagnoses, refinement of diagnoses, different options. Go back to our radiculopathy versus carpal tunnel, classic example. Sometimes just having a different set of eyes in a problem can completely change the case. There may be times when I say this person absolutely cannot go back to driving a truck, so let's move on. Let's get them retrained.
Yeah. So, and that leads into the next question about what impact do IMEs have on the employer-employee relationship? Could affect the actual job assignment, right?
Yes, you and I have talked about this before, about the institutional barriers to return to work. And as an occupational physician, you know way more about those than I do. Getting a person back to work by the time they get to an IME is difficult because they're already weeks to months out, maybe years out from the injury, and may not have worked for a long time. One of the things that I think, so kind of the easier answer to that is trying to move the case to an IME faster, which is very difficult to do. That's really out of my hands and out of the treating doctor's hands. The second one is resolving work disputes, return to work. For example, I see patients who've had low back fusions where the fusion's intact. There is bony fusion, and that person is given a lifting precaution, but they can't lift over 35 pounds. And some of my mentors have said to me, well, they're better now. They're fused. Why would you think that that fusion, where there's bony union, would require
Limitation.
limitation, work lifting limitations? And I
Yeah.
have to admit that I used to limit someone who's had a fusion to no lifting more than 35 pounds. And it took some education on my part to kind of think of those dynamics differently. Now, would I have everyone, would I do that across the board? No, this is the finesse of what we do. What's the conditioning of that person? What's their overall body mass? What's their general, how long have they been laying in bed? What's their pain tolerance? So getting back to that risk capacity tolerance equation, that can help the IME move a case forward to resolution, can support the OCMED doc.
How often do you recommend an FCE in those cases? Or do you always have them? We don't always have them ahead of time, right?
I do not always have them. And this gets back to that risk capacity tolerance equation again. And this is fundamentally important, this massive concept here, sorry. When we are talking to our patient, we are talking to them in terms of tolerance. What can you do?
Right.
What do you feel you can do? When I'm evaluating a patient, I am evaluating them in terms of risk and capacity. Risk, is it safe for you to do the job? Will you hurt yourself? Will you hurt somebody else?
Right.
2, capacity. Do you have the medical capacity to do that job, and why? You have the strength? Can you bend? Can you lift? Can you raise your arm? Would you be able to do better with physical therapy? Because this physical therapy is really about improving capacity if we're doing it well. I'm thinking in terms of risk and capacity as an IMB, but also as a doctor. Whereas our patient is talking to us in terms of tolerance.
Yeah. Hurts when I do that.
Hurts when I do that.
I can do it, but it hurts. Yeah.
Yeah. So that's the fine part. So when I'm looking at a person, I'm trying to do it objectively. I will say, it is absolutely unsafe for a person who has dizziness to look up, to be on be at heights, or epilepsy, be at heights around moving equipment. That's easy. But the finer point is, what can that person do?
Yeah.
What's safe? Okay. What can they do physically? But then tolerance can be, well, can their workers tolerate them having a seizure on the middle of, in the office? So different types of risk capacity and tolerance all go into the equation.
When the treating doctor receives your IME report, what do you hope they're going to accomplish with that?
I try to write my reports in such a way that it helps the treating doctor. I'm trying to write a report that moves the case forward. I'm trying to write a report that resolves the case and leads to a better outcome for the patient. If I were treating a doctor, though, and somebody else, my patient went out for an IME and this IME report comes back, I may not see those subtleties. So what I'm hoping for, first of all, I'm hoping my report gets read. Secondly, I'm hoping that someone thinks some of the ideas are worth pursuing.
Yeah.
And thirdly, I'm hoping that the receiver understands that I wrote the report with some sort of grace to facilitate care.
Yeah. And what if they disagree with the results of the IME?
A lot of that is actually a systems question.
Yeah.
In most states, the treating provider has the presumption of correctness, or is considered correct over a medical legal provider or an expert.
Yeah. So they're using that as another piece of information, but they're making the decision.
Yes. Sometimes the claim will be closed or kept open based on what I say. So that sword can cut many different ways.
Yeah. And it varies by state, right? We have patient choice states where they can order their own IMEs, and we have other states where pretty much only the adjuster or sometimes the treating physician is ordering the IME.
Mm-hmm. I will say it's unusual for me to get a report back. There are times when we can get into this, we can lose some objectivity with our patients sometimes, which is a good thing because we are normal. Okay. And there are times when I'll see the same person back for an IME, or I'll do an IME when somebody else has given an opinion and the treating doctor says, this person doesn't want to know what they're doing. This IME is completely wrong. And maybe the treating doctor is correct, or maybe the treating doctor is just got his or her heels dug in. And there are different issues. Where I see this a lot is people with headache, neck pain and headache, and they've had multiple rhizotomies, medial branch. They've had multiple injections, ablations, and their headaches keep coming back. And I'm like, maybe we should stop putting needles in their neck, and maybe we should look for a headache diagnosis. And it's amazing how much resistance I get to that concept.
Interesting.
Yeah.
Yeah, then you want to go back to your other biopsychosocial aspects, right? Go get a massage or try chiropractic or try something completely different.
1 in 5 women has migraine. Okay. Half of women, 1 in 10 men, half of us don't know we have migraine. We've been diagnosed with just something else, or we haven't been diagnosed at all. And 30% of us have been told it's from our necks. So, and that's 30% of the people that meet international classification of headache disorders, diagnostic criteria for migraine, when they come into a headache center of excellence, have been given a diagnosis of cervicogenic pain.
So there's a lot of undiagnosed migraine out there.
And if you think about the person who is, let's just take whiplash, and I'm taking whiplash because people it's both personal injury and it's also OCMED because somebody's driving and they get rear-ended and
Sure.
their head hits the back of the headrest, and they go in and they've got headache and neck pain, and they're severe headache, red flag for migraine. Severe headache, they go to chiro, they get better, they flare, severe neck pain, severe headache. I'm thinking migraine. Okay.
Yeah.
And
good point.
I'm the person who's just seen him have 20 chiro visits. So I'm getting all those records retrospectively, and I can say better flare, better flare. And then they've gotten a little narcotic, and they've gotten maybe some butalbital, and they're getting chronic daily nonsteroidals and maybe a little soma. And all of a sudden you've taken that person with a treatable headache disorder and you've pushed them into chronic daily headache with medication, with overuse, multi-pharmacy. Now, how are you going to undo that? So that's one place where I think the IME can give you, it's a huge place. The IME can give you a different set of things to think about.
Yeah, and that's such a problem, because then when you're making that assessment, that is essentially ending the work comp case, right? The migraine is not a work comp issue. So all those doctors that loaded up all those drugs now are not going to be necessarily seeing that patient anymore. Could open some additional issues.
That entire problem of, well, you're work comp, so you're in this box, but if you're medical, you're in this other box. And that's very difficult.
It is.
So how do you, So that whole concept of how do you detangle a headache,
Yeah.
maybe it is related. Maybe it is, there's migraine and post-traumatic headache. That's where an artful answer can make a huge difference. If we treat you for your post-traumatic headaches and get you back to your migraine baseline, you will be better off. But the person who's sitting there in a dark room every day with chronic daily headache, you're not doing anybody a favor, work comp related or not, by not moving that forward with correct diagnosis.
So you would still recommend a treatment plan that would move that person humanistically and compassionately through that process.
Yes, and that's very complicated because
Yeah.
it breaches. It kind of has a foot in both the workers' comp and the pre-existing.
Yeah.
It's complicated because people are afraid of treating migraine. It's it's hard to get a person to necessarily do some of the medications. People don't understand the nutraceuticals, and I realize I'm getting off on a tangent. There's an artful answer. My point is, there's an artful answer when doing an IME towards moving a case forward. And sometimes that's within workers' compensation. Sometimes it's getting it out of workers' compensation. Sometimes it's sending a person back to work, whether they want to or not. Sometimes it's keeping somebody out of work, whether they want to or not.
Whether they want or not. Yeah. Yeah, and I think those are some of the areas where I hear from physicians, treating physicians, that where they may have disagreements is, they're saying, this is pre-existing. Every patient I send for an IME, I get back, oh, this is pre-existing. But you're saying, well, there's a way to transition that care properly, and as I said, compassionately, to make sure they still get the care they need.
Yes, and also saying, right to what you said, that entire concept of this was pre-existing. Okay, so when is it pre-existing? When's it aggravated? When was it pre-existing asymptomatic and now made symptomatic? So that concept of lit up. And this gets back to the conversation we've had about causation before.
Yeah.
If I don't know why something got broken, it's going to be really hard for me to fix it. So when the IME comes back and says this is pre-existing, it may be a way of saying that not all the symptoms that occur after an accident are necessarily related to that accident. And how do you sort that? And how do you take that? Well, this is all pre-existing from the treating physician's point of view, who's been the person in the room. I've seen him once, this person's seen him all the time.
Yeah.
How can the causal assessment, the causation of the injury, help with diagnosis and appropriate treatment? And I think that is actually a huge conflict between the IME and the clinician, because IMEs have a different sense of causation.
Good, thanks for that. Just a couple of minutes left. I just wanted to touch on what are some of the emerging trends in technology. A lot of technology out there now that we can use for evaluating our reports and report writing and all those sorts of things. What do you feel like are the most interesting trends in conducting IMEs or medical legal work is?
So AI is going to be huge. And we could talk about AI, but by the time we get done with the sentence, it would have, moved on past us.
Yeah.
One of the big things is going to be integrating AI intelligently. AI is full of mistakes. And whether I am when I am doing an IME, there is no substitute for me being in the records myself. You and I see paper differently in a medical chart than anybody else. We can read through, there are maybe hundreds of words on a medical chart, but you and I are looking for the 3 words in the musculoskeletal examination, or did they actually put a stethoscope on the heart, or is that text, is it standard language and you can't trust that exam. That's all something you have to see on the page.
Yeah.
So no matter how good this technology gets, it's not going to replace you and I as the clinicians. So my concern with AI is not that it's going to do a better job, because it's going to be faster, it's going to make things easier, it's going to streamline things, but it's not going to take away my need to do my job. That's one. The second one I think is actually very important is big data and claims and patient claims. And the big data and the AI is going to, if we're lucky, identify the at-risk patient earlier.
Yeah, you mentioned that before.
And
How do
it
we
may
get them
be,
in sooner? Yeah.
yep, maybe if we're lucky, that system will identify the at-risk person, set up a different paradigm, help the treating doctor, and avoid having to go to an IME.
Great point. Well, I think we're going to have to leave it there. Another fascinating discussion with the wonderful Diana Kraemer. Thank you so much for being with us today. And we will cover additional topics on IMEs in subsequent sessions.
I look forward to seeing you again, Larry.
All right. Take care. Bye now. And that wraps up another episode of Fit for Duty. Thanks for joining me today, everyone. I hope you found this conversation as engaging and informative as I did. As always, building healthier, happier workplaces starts with knowledge and collaboration. So if you enjoyed this episode, please consider subscribing to Fit for Duty wherever you listen to podcasts. That way you'll never miss a beat when it comes to the latest trends, best practices, and inspiring stories in occupational health. Until next time, stay safe, stay well, and keep elevating workplace excellence.